All right, well, welcome back. We're going to go on to the live cases, but first we're going to talk a little bit about the poll results, and I believe that you're going to be able to show those poll results on a separate slide, and we can maybe just talk for a second about it. Can you pull those up, please? All right, so... Okay, even though we sort of poisoned the well and we talked about calcium, drug-coated balloons still beat it out by a smidge. So that's okay. I think that all of these, frankly, are areas where we like to see randomized trials, and I will certainly be seeing trials of the calcium modification later this year and the drug-coated balloon versus drug-eluting stents. Those trials will be ongoing and hopefully reported out in the next couple of years as well. So we'll be seeing these. And the first topic, we've seen a fair amount recently. So I think our audience is certainly clued into what's hot in the coronary space. And let's show more examples of that with these live cases that we're going to see from Erasmus and Leipzig. If you can go to that intro. Perfect. I think we see you live, Nicolas. How are you?
Okay. Ajay, can you hear us?
We can. We have Azeem, Margaret, and Giuseppe here, and we can see you and hear you very, very well. And you're going in with an atherectomy device, the OAS system.
Yes, yes. All right. So, so good to have you in the Paul Hugenholtz room at the moment. Let's pause here. This is the first live case of the day, I assume, so welcome. I will do the case together with my colleague Wijnand en Dekker, and then we have Alisa and Pluis, aka Louise, in the room as nursing support, and then John and Quinten as technical support. Let's bring on the slides of the case. And maybe Wijnand, you can run us through the case.
Also, welcome from my side. So we will do an orbital atherectomy case in a heavily calcified LAD. We have a 75-year-old male patient without, until recently, medical history. He has some risk factors: hypertension, hypercholesterolemia, and diabetes. And he was referred from another hospital because of a dyspnea upon exertion and reduced exercise tolerance. Next slide, please. So on physical examination, he had a systolic murmur. His EKG was normal with a sinus rhythm of 61 per minute and a left anterior vesicular block. And then on echo, he had a good systolic left ventricular function, but it turned out he had a severe aortic valve stenosis with a maximum speed of 4.6 meter per second and a peak gradient of 87 and an AVA of 0.7. His laboratory values, he had the normal HB and the normal kidney function. Next slide. So this is maybe a little bit small to see, but this is the coronary angiography, and the right is, well, not the best, but there is no significant stenosis in the right. And then on the left system, he has a calcified stenosis in the mid-LAD. So we discussed this patient in the heart team for a low, and it was discussed that it was a low-risk surgical valve replacement. Next.
And maybe, so Wijnand, in the Netherlands, then in principle, there is no reimbursement for low-risk patients for TAVI or TAVR. But this patient was qualified for a low-risk prospective study that we are participating. And in that context, the patient would become eligible for TAVI. So that is why we are bringing him back to the lab today to treat and take care of his LAD. And so the calcific severe stenosis in the mid-LAD is our target for today. And then I think a week or 2 weeks from now, we will treat his aortic stenosis with a TAVR. That's basically the plan, right?
Yeah. So we decided to treat the LAD first, and maybe the next slide. And well, I heard you were talking a lot already about orbital atherectomy and also about the ECLIPSE study, which has finished enrollment, I think. And well, we are also conducting a study with orbital atherectomy. We just recently started, actually, and it's called the CROWN study. It's calcium reduction by orbital atherectomy in Western Europe, and we will prospectively prospectively follow 100 patients with severely calcified coronary lesions that will be treated with orbital atherectomy and OCT guided. It will be in the Netherlands, in Germany, and in Italy. 6 centers will enroll all the patients. In the Netherlands, it will be us and the Catharina Hospital. In Germany, it will Cologne and Essen. And in Italy, it will be Alessandria and Rome. And we are actually, we enrolled the first couple of patients.
Oh, the study has started 2 weeks ago. This is patient number 4, and it's heavily focused on OCT, right?
Yeah,
So
yeah.
we really want to try and understand how we will modify the calcium and whether we really are able to not only create superficial fractures but also interact with medial calcium. And basically, per protocol, we would want to have at least 3 OCT runs. So OCT at baseline, OCT after the orbital atherectomy, and then OCT after stenting. Wijnand, what have we done so far?
Yeah, so the setup is we have 6 friends radial access, and we have a CLS 3.5 guiding. We made some first films of the left system.
But let's see, Ajay, any comments so far, or the panelists, Giuseppe, Azeem?
No, I think it's just we're in our ear. Leipzig is rearing to go because they have to do something. But I know you're set up to do atherectomy, so I think that what I think we should probably do is watch you do the atherectomy, and then we'll go quickly to Leipzig. So why don't you start? And as you're starting, I can talk a little bit. Let's do that.
So what
I think first.
So we'll go in for 5 minutes. So we'll show you the baseline OCT and the first angio. So briefly show the angio. So not much discussion. This is severely calcific LAD disease in the mid-segment beyond that diagonal branch. And then we did an OCT. So why don't we bring on the OCT?
Yeah, now
And then Quinten briefly help us through.
yeah, so we start distal, of course, and that is quite normal. But here starts calcium already, and then we found already almost there at the beginning already 360 degrees of calcium, and it's most over here. And we see this in the software. It's an automatically tool. The AI tells us.
And for those that
more
don't
than,
have this, this is the new Ultron system, which is really remarkable in terms of the use of the AI to identify calcium length, et cetera. Go ahead, keep going. I just wanted to set that context for the audience because many don't have access to this.
Okay. Yeah, so I put a threshold on 270 degrees because of the Crown study. They request the 270 degrees threshold for calcium. And here we see an angle of 334 degrees of calcium. And yeah, you see in the picture over here, you see, I think 360 degrees, but because of the wire, yeah, you cannot see calcium over here, so the software excluded.
That's clear, Quinten. And can you press play that we briefly have the entire run?
Yeah, so I will scroll.
Yeah, so scroll to the proximal part.
Yeah.
And so you appreciate over 40 millimeters of calcific
so the software
disease.
detects automatically, of course, and that's in the orange, where it's more than 270 degrees. So I go, here's the MLA. Here the software said that the MLA is the distal part, but I think here is also.
But we had segments of 1.1 millimeter square.
Yeah.
But so you had this threshold of 270 degrees. Just for argument's sake, briefly go to 360 degrees.
Yeah. And then it disappeared totally.
Oh, so why is that?
Because of the wire.
Yeah, that's
because
what
of the wire. Because of the wire.
Yes,
maybe because
exactly.
of the wire.
Exactly. So
Yeah,
we go
so
to
I could answer
320.
already.
Go to 320.
320, yeah.
And then
300,
you
320.
really identify now the areas where there is 360 degrees of calcium. So this is a very nice tool that immediately directs you to the hypercalcific areas in this vessel. But I think given the length of the disease, this is a very good case for atherectomy, rota or orbital. You could also consider shockwave lithotripsy, but obviously the length is a little bit of an issue and you might end up using multiple devices. So that's why Wijnand will start now with a run of orbital atherectomy. So go ahead.
I think,
We
from my
typically go.
perspective, okay, go ahead. You can tell us how you do it first.
Well, Wijnand wants just a second. Yeah.
No.
That's nee, wacht. Yeah. So we briefly want to reposition the wire. The wire was. So why don't we put this on? That's altijd gemakkelijker. Okay, so it's important to have the wire
Put it on the
nice and distal.
base
And
at 5,000.
yeah, so
To be able to then release the brake and advance the wire, so pretty easy to re-advance the wire.
Yeah.
And then now he'll come in with the atherectomy device.
yeah.
Okay, we will start now.
So, and we typically do this at 80 RPMs. You have also a higher speed, but I must admit that I hardly use the 120,000 RPMs. And as Wijnand now is progressing at 1 millimeter per second, you can hear the sound, and the sound changes. And that is when the orbit interacts with the calcium. And then after 20 seconds, we'll get an alarm. It's no problem. So we now go slowly back. And this is the nice feature of orbital atherectomy. You have bidirectional lesion interaction and lesion therapy, if you will. With rotablation, it's only antegrade. Here we go bidirectional. So that was nice. We give it a pause for a second. And that is basically the essence of orbital atherectomy.
So a few things. One is that the technique is much different than rota. You're going nice and slow and smooth through it. And there's several features that favor, I think, in my opinion, orbital over other approaches here. Number one, the lesion length is longer. And as Nicolas mentioned, then for other techniques, you might have to use multiple inflations. The second is the patient has severe AS, and there tends to be less hemodynamic instability, partly because of the size, but also because of the flow rate. And then the final point is because the MLA was actually not that constrained, in order to get effective debulking, you kind of need the orbit to get around unless you took a bigger sized burr. And so for several reasons, I think this is the type of case where it's probably ideally suited for orbital. I think we've lost the feed on Nicolas, the sound part, but we see what you're doing, which is more runs. And so I think you're going to go back with the imaging to see what the imaging did. And so while you go ahead and do that, let's go and jump to Leipzig, and then we'll come back to you right after that.
Okay. Excellent. All right. Doe nog een,
All right, why don't we jump to Leipzig? Sorry to keep you waiting, Dmitry, Holger. Good to see you.
Yeah, good to at least hear you. We can't see you currently. We only can see ourselves.
We can
welcome
see
from
you,
Leipzig.
Yeah.
That's very good. So on the left-hand side, this is Dmitry Sulimov. He is doing he's the first operator. I'm more assisting him, and I'm trying to talk and presenting the case and what we aim to do. Maybe we can get up our slides. So we have next slide, please. 70-year-old male patient here. So as you can see it here, he had formerly a PCI of the right coronary artery, and now several months or years later, he presented now with new angina, stable angina with CCS class 2. Importantly, he has no diabetes. He has normal ejection fraction and no relevant significant comorbidities. Next slide, please. And so this was the initial angio, which we have done. As you can see, there's a good result, long-term result in the stand of the proximal RCA. And we have a calcified eccentric stenosis of the LAD, proximal LAD, as you can see it here, just before the first diagonal branch. Next slide. And we, as already mentioned, so this is another projection. We have a short calcified lesion, which is eccentric. And also, as you can see it from this projection, it seems that there is an ostial left main lesion. At least what we have seen, there was some wedge pressure when we intubated the left main, the ostium of the left main, during the diagnostic angiography, which has been done a few days ago. Next slide. So, initially, we tried to do an ad hoc attempt to cross the lesion, to do an ad hoc PCI. Nevertheless, we were not able, or at least the operator who has done it, he was not able to cross the calcified lesion in the LED. This is what we now plan for today. We aim to, or this is what we already have done. We can show it to you with a microcatheter. And a hydrophilic wire, we were able to cross it. We want to do a rotablation, and then we also want to do an EVIS-guided PCI of the LED and evaluate the ostium of the left main. So next slide. I think this is already what we have done. Yeah, and we can show you directly. Maybe we can go to the fluoro. We can show what we have done so far. So this is the initial angio. As you can see it, you can see the eccentric lesion, calcified lesion. We have put in a BMW, a workhorse wire into the left circumflex, just to prevent from wedge pressure when we intubate. The guide wire, the guiding catheter. Then we were able to cross the calcific lesion with a small catheter, and also with a Thiele XT. This is what you can see. Initially, we were only able to wire the first diagonal branch, but this is the situation what we currently have. So we have the Thiele XT wire in the distal LED. We have a BMW wire in the left circumflex. And this is the current situation where we are. And now
Actually, we exchanged it already for rotor wire.
Oh, okay. This is, yeah, okay, this is also important. Yeah, we already exchanged it for the rotor wire.
So
this is important, yeah, because we aim to do a rotablation.
Does the microcatheter cross? Yeah, but it's glad that the microcatheter crossed. I
Yes,
think the
but it was
technique
very,
used
very
to put it in the diag first.
With the microcatheter.
Yes, this was a...
I think it looks like it's eccentric. This is a perfect case for rotablation. So that's great.
Yes, correct. So we were able to cross it with the fine cross catheter, but it was not so easy to be done. This is also the reason why we decided not to do or try to perform an IVUS before PCI, because we are nearly 100% sure that we will not be able to cross the eccentric calcific lesion. So as mentioned, we already exchanged the wire to a rotablation wire, and Dmitry has already chosen a 1.25
Exactly.
bore. And as you can see, maybe we can have a little bit closer look on it. So
We have to test the speed of rotablation.
this is what we do now. Okay.
A little bit more. It looks good.
Because of some of
So
the
we
velocity
tested it
and
with
because of
160. Sorry. We tested it with 160 RPM. And this it's a little bit higher than in comparison to what the Erasmus group has just done. And now we advance, as you can see, the rotablator up to in the guide wire, or in the guide catheter. Pull up. Then
So
we
here
just-
Dmitry, I'm curious. You did that without putting it on Dynaglide. Do you typically do it this way because it's more secure? But many people just use it on Dynaglide to bring it in. What's your thought?
I don't know why do I do it in this manner. It's just easy.
so
And it works.
As you
it
can
works.
see-
It's all good.
Yes, exactly.
Dmitry also even sometimes doesn't allow me to help him, so he is doing it with his two hands and everything is fine. So he could be a single operator for this procedure.
Thank you. Well, it's already here, difficult to cross. Here we are.
Yeah, there you go. There you go. Dmitry, can you tell us why you picked the 125 and not the 15?
Well, I was not sure we are able to cross this with 1.5 because the artery is not very big and it's very, very eccentric and calcified lesion. I would like to start with 1.25 with smallest available bore, because the aim of the rotablation in our case is not to remove as much as possible plaque material, but just to enable sufficient stent expansion. Our next step is IVUS to evaluate the diameter, and after that, pre-dilatation. If we succeed to pre-dilate the lesion with 1.1 sized balloon, we don't need bigger bore. If not, we can upsize.
Any thoughts from the panel on that? It obviously worked very well and it was safe. Any thoughts otherwise?
Yeah, I
Margaret,
think,
Giuseppe?
some people might argue that with the kind of slight angulation over as LED dips over towards the diagonal bifurcation, that there may be a small risk that with the smaller burr you could get stuck beyond what we presume is a nodule there, so it crosses easily and then gets stuck on the other side. So some people might argue you would be better to go with a 1.5, but there's always many ways you can do things and lots of differences of opinion, and I think either way is entirely fine.
Yeah, and I think one of the nice things at least is that right now we have dueling rooms, one with orbital, one with rota, and because orbital you can do both directions, actually there's going to be modifications to the rota burr that allow you to actually burr on the way back as well. So it's always good to have multiple devices because each one pushes the other one to get better, which is great.
But I think maybe
Margaret?
in a lesion like this, where it was really difficult to cross, they were struggling also with the microcatheter. To me, it makes more sense to start with rota, whereas the lesion I saw with in Erasmus, I think either would be fine, but I tend to prefer when difficult to cross lesions to really do it with rota.
Exactly. No, I think that's why it's so good to have the two cases contrasted too. Margaret, were you going to say something?
Yeah, I just wanted to play devil's advocate with the Erasmus case. So on the OCT, although the lesion was long, there was only two focal areas where the calcium was more than 270 and particularly up towards 300. And the proximal, we can discuss this when we go back, but the proximal lesion was very thin. The calcium was very thin. And the distal lesion, the calcium was thick on one side and thin on the other side. So you could argue that actually, although the lesion was long, the calcified segments weren't so long, and maybe alternative options would have been also appropriate.
It's actually a great cue that we need to go back there and actually look at their imaging and what they saw. So what you're going to do here, Dmitry, you're going to IVUS and balloon. Is that right?
Yes, exactly.
So maybe what we'll do is we'll stick with you for the IVUS. Yeah, let's stick with you for the IVUS, and then we'll go back to Erasmus to see exactly, because I think that's a very, very important point that Margaret made as well. So it wouldn't be surprised if it's hard to deliver the IVUS, because even if you're using a low system with a 125 boat by itself, you make a channel, but it's tortuous as well. So it looks like you're going to probably have to balloon this, I think, before the IVUS will go, which is okay.
Yes, exactly.
So maybe, or with slow patient pressure, I don't know. This is also where you have to, you don't want to push too hard for safety purposes. Obviously,
I can break the IVUS catheter.
Exactly, or get it stuck. So I would just go back with a balloon, dilate it, and then show us what the IVUS looks like at that point.
It's exactly our plan.
So this is now our plan. So nevertheless, good luck.
Bigger plan.
Dmitry has been able to cross it.
It's done.
It crosses everything.
Okay.
With some gentle pressure.
Okay, so let's see what the IVUS looks like. By the way, there are techniques to get the IVUS forward. You can put a balloon on the back of the wire and push it, but I would not recommend doing that in this situation because it could get stuck. So here we go. Eccentric calcium 9 to 6 or 6 to 9.
All right. So we have Dr. Hans-Josef Heisritzer. He is at the
go ahead.
console of the IVUS catheter, of the IVUS machine. Once again, showing everything. Yeah, so there's, as you can see, eccentric calcification.
And then after
in the narrowest place, it was nearly 360.
360.
Okay.
That's right. So I think you're certainly going to have to do more, lesion preparation. The Rhoda made a channel, but now you have to prep it to see if you can crack it, and then after that, probably re-image.
We will start with non-compliant balloon.
Yep.
And if we not succeed with the lesion preparation using non-compliant balloon, we will upsize the rotablator.
Yes, I think this is a good plan.
Reasonable approach.
So what kind of balloon do you want to have?
2.5 by 8 non-compliant balloon, please.
Okay. So let's jump over back to Erasmus. You do your work and see if it expands. And then after that, you could either do rotablator or you could take an IVL if it were able to cross, or other balloons. But let's go back to Erasmus so we can see what the folks there have done. Margaret.
All right.
Okay, go ahead. Hey, Nicolas, sorry to keep you waiting so long. Let's see what you guys have.
No problem. So we have been working a bit. We did an OCT after the orbital laterectomy. So maybe we can briefly show that, Quinten.
Yeah. Instead of the result of the orbital, and I think over here it's the. Yeah, we see some little, fractures over
disruption
over here
there
in the disruption, in the calcium, but it's more or less in the middle part. Is it?
So the interesting part is that especially in the proximal segment, we see an effect of the orbital more distally. It's very hard to differentiate whether we did something or not. So if we go to that segment, I go a little bit more distal. Yeah, you see a lot of calcium, but somehow it's
you don't see
difficult. Maybe there it.
No.
Yeah, it's difficult to
I
appreciate.
don't see much effect from that.
No, I mean, I saw disrupted intima media. I didn't really see a fracture in the calcium. Now, what can happen is if you go with a balloon, it could be you can have prone to calcium because there's been some force, but this is not, to be honest, that distal lesion the most impressive thing. Margaret had made the comment before, looking at the initial OCT, that this area of concentric calcification that was thick is over a relatively short segment. So, devil's advocate, if you weren't going to be doing atherectomy, if the patient wasn't in a trial, could you use a balloon or an IVL or something like that in that area?
Absolutely. And as a matter of fact, so we had the same sense that you have, and Margaret's suggestion is well taken. So the next step was to use a 3015 non-compliant balloon. And can we briefly show the stored fluoro image, how the balloon got there? So this is okay. So here is the balloon. Not going, so een eentje terug.
No, here it goes. No,
Okay, so next.
Ja, dat is een lange.
Okay, so here, so Wijnand, did we encounter any issues there with the balloon?
No, I had to reposition the guiding, and now it went smoothly.
See, very smoothly.
There you go. Yeah.
And then next, so that already tells you that okay, reassuring. And then
this
is
looks
a
like it expands
3015
well.
balloon.
Yep.
Yeah. Balloon is well open.
Yeah. So this is 20 atmospheres.
Yeah. 3O balloon.
And then we go more proximal. So next. Next.
Go ahead, Margaret.
So Ajay, you obviously have a lot of experience with orbitals. So although we didn't see much modification in OCT, do you think the calcium got thinned by the orbital and that's why the NC worked there? Is that what you think happened?
I think that you should be able to see that by OCT if the calcium is thinned, and usually you'll see the device in a groove and sort of modification in the groove, and I didn't see that. What I don't know is that was there some vibratory force on the calcium that made it more prone to fracture or not? There's no way of knowing that, but that's one of the reasons why the OCT sub-study of Eclipse is going to be really interesting, because I think it'll give, first of all, it's randomized, but second, in the OAS arm, you can hopefully see these types of things and ask these types of questions. But I just don't know. And you could just argue maybe the NC from the beginning would have worked. And I think many people would have said we needed to do IVL, but here the NC seems to work. Azeem, what do you think?
And I was just going to ask Nicolas. Nicolas, I mean, you enrolling in the fracture trial, Could this patient have been enrolled in that? So the fracture is a new trial with a new IVL device, or was this lesion a little too long for that?
Too long,
Too
I
long.
think.
So the cutoff is 40
Okay.
millimeters. And by
Okay.
OCT, the length of the disease was 44 or something. So, yeah,
That's
this
just too
would have
long.
been a formal exclusion. Yeah.
Yeah. Nicholas,
Would be
did you
interesting.
Can we have
re-OCT
the
after
look
the
at-
NC balloon?
Unfortunately, we did not do an OCT, so we immediately got in with a stent.
Yeah, it's okay.
But now
Yeah, that's
we
fine.
are struggling to get our OCT catheter down. So let's use a new one.
But it looked like the stent expanded very well angiographically, at least, right?
Oh yeah.
Yeah.
Oh yeah.
it did.
And then you post-dilated it as well, or not yet?
Not yet. So, but can we briefly show again the stent inflation? So this is the stent at 12 atmospheres. So this looks very well expanded to me. Yeah. So somehow the compliance of that vessel is not that bad. So let's see how it looks by OCT, and then determine how aggressive and where we need to do our post-dilatations. But first, obviously, we need to get this catheter down. I must say, if you use multiple runs of OCT interrogation, it sometimes becomes more difficult to get the catheter down.
You know, for
We have an
me, I mean,
extra
I think the
backup
way
catheter.
the way the
Sorry, go
balloon
ahead.
expanded was good, but typically in these cases, we tend to try to go back with the imaging modality, either IVUS or OCT, prior to putting the stent in to confirm that there was adequate fracture so that the stent will expand. But you know, I think your points about the catheter utilization, et cetera, are well taken. Probably what needs to happen is just post-dilatation of the stent first to make it big,
Yeah.
and then go back with the OCT at that point.
There may just be a couple of struts at the
But-
proximal edge that are not well opposed.
Best not to force it because you can lift something up.
3,5, 15, non-compliant balloon.
But that's okay. But I think it's super interesting because I literally looking at that first imaging, there's so many different ways to treat this, and the fact that the NC balloon yielded was very, very instructive in some respects. There are other people who would use cutting balloons or scoring balloons. There are other people who said, well, there was no way the cutting balloon would deliver because the OCT can't deliver through the proximal vessel. So there are a lot of ways to do these types of cases. Giuseppe, you know, is that your sense too? I mean, I know you were pretty prescriptive that you have a certain algorithm that you use, but even when you have algorithms, there are times when you get very surprised by the fact that certain things fail, and then you have to go and be more flexible, right?
I agree. It's a case by case. Actually, as I told you, I prefer perfect cutting balloon. Because actually, you can downsize 0.5, going up to 40 years and without cracking the clutch. And actually, it's case by case. I'm not dogmatic at all.
Doe anders zien, ja. Ja, dat is goed, denk ik.
Margaret, go ahead.
Okay.
Yes, I think the most important thing is always to be alert to not under-treating before you stent, because obviously the worst thing you can do is put a stent in and then it's under-expanded. And even, you know, a lot of very experienced operators still get caught out with that every now and then. So I think you're having your level of suspicion very high. You haven't adequately dealt with the calcium until you're convinced, either with your imaging or alternatively by looking at your balloon expansion in multiple views to make sure you're not being tricked by seeing expansion in one view and not in the other. I think always just have your suspicion high until you stent.
Yeah. All right, so we're going to jump back quickly to Leipzig. I know you guys are going to do the OCT right now, and then we'll look at the OCT, and you keep working, and we can come back to you. So go ahead.
All right.
To Leipzig. All right,
Yes,
Dmitry, Holger,
I can hear
we see a bigger balloon in the vessel, which is great, and a stent, I think, too, maybe.
Yes. Yes, maybe go back on what we have done in the meantime.
Yeah, tell us what you did.
In the
Yeah,
meantime, when you have
the
yes, just
we left you at the
going
2.5
back
NC.
to- Yes, correct. And this is what we did. So, so we pre-dilated the lesion which we had prepared, and this was easily be done with a 2.5 NC balloon. We did an IVUS afterwards. We saw that the diameter of the LAD in this part is 2.5 millimeters by 2.9 millimeters. And that's the reason why we decided to go for a 2.5 by 12 millimeters drug-eluting stent. And this is what we
Can you show us
done.
the
So we
fracture,
have
though? If you don't, on the IVUS, we're seeing the IVUS on the bottom left of our screen, which is great. But if you don't mind, can someone just scroll towards the point where the
we see
nodular thing
IVUS
was and the fracture?
before pre-dilatation. It's IVUS immediately after rotablation.
Yeah, so we saw the IVUS, as you can remember, directly after rotablation. Then we have done, this is what we have shown to you live. So where we had the eccentric calcification. Then we did the measurements afterwards. And we also, this is important, we did a measurement of the ostial left main. If you go back to the IVUS, if you can show it.
But Holger, did you do the IVUS after the 2.5 balloon to show the fracture, or no, you didn't do it?
No, we didn't.
No, we didn't.
Okay.
Because we were happy with balloon expansion.
The balloon, okay.
Now probably you should see it. So this is the measurement of the ostium of the left main, which is 6.4 square millimeters, where we believe that this is not required to put in a stent into the ostium of the left main. And that's the reason why we stick only to the LAD. As mentioned, we have put in.
Yeah, it looks like I think the ostium of the left main is this 6.7. Yeah, and that other thing was more distal, but yeah, okay.
Yes, correct. And this is what Dmitry in the meantime has done. So we have put in the stent. We have post-dilated it with a 3.0 non-compliant balloon. This is what you can see now. And
now we're going to acquire IVUS images.
Yes, and we can do now a post-PCI IVUS. And this is what Dmitry already has done. He has exchanged everything to the IVUS.
So let's see.
I start the pullback.
Yes, he's starting the pullback, and we will see, hopefully, a good result. Good stent expansion, stent apposition. All right. So this is still distally. Here we go.
Yeah, and that's in the area where the calcium was more eccentric there. And what's interesting is that the IVUS catheter lays the same way as it did before. It looks very good there. This is that nodular type of area. This is the more concentric area, and everything looks great, to be honest.
Okay.
Yes, even after post-dilation, I think this is a good result. And hopefully you agree that we don't go for the left main. I personally think that we only had to treat the eccentric calcific lesion in the proximal LAD, according to what we have also seen in intravascular imaging.
No,
I will give some nitro and make final angio.
If you just go back to the IVUS image for a second, with all the different systems of imaging, sometimes, and this actually happened when we were looking at the left main, we were looking at the other lesion and we thought it was the left main. The D, you can see a D there and a P at the bottom. I actually went to Minneapolis to look at the new IVUS systems, and the most important thing I learned is that there's a D and a P, distal and proximal, that tell you which way it's running, and that way you'll never get mixed up. Anyway, this looks great. So as you can, it's a good demonstration.
Yeah, so we don't have a D and a P, but anyway, you can see.
No, you do. You do. You see it? You can see it at the bottom left. That tells you it's distal.
Okay.
And P tells you it's proximal.
Okay. Very good. So I have learned something during this live case. Very good.
Exactly.
Final angio?
Yeah. So we.
Yeah, go ahead.
We do a final angio. So this
now, ordinarily you'd calculate an MSA as well, but this looks wonderful.
So maybe a little bit better contrast
Yes,
filling.
I'll try.
Okay. So second final angel.
Second, yeah, very final.
Yes.
Oh, that's a great
Actually,
job.
Looks quite good.
I think this
You
is
made a
fine,
tough
so
case
we
look
shouldn't
very
do
easy.
anything
That's
else.
great.
Thank you.
So we really appreciate it. I think it was a great demonstration of everything, and great rotablator technique. Thoughtfully choosing the microcatheter exchange for that, and then showing how the imaging helps. So I think really nice demonstration. Thanks to both of you. And Holger, your voice held up. Thanks for that.
Yeah, so hopefully it will be even better tomorrow. Yep. Bye-bye.
So as we go to Erasmus, any comments from the panel, Azeem or Giuseppe, Margaret? Azeem, what do you say?
No, I think, good case. It just shows, right? I mean, some of us would have gone with 1.5, others 1.25, but it just shows a well-conducted case, well-wired in a calcified lesion using a microcatheter and a polymer jacketed wire, then exchange to rota, getting a good result with rota, pre-dilatation, stenting, and IVUS guidance. I think, what was a potential complex lesion done very well and
So, wir sind
didactically.
fertig und wir sind sehr zufrieden mit dem Ergebnis.
That's great. So let's go back to Rotterdam and see what they have. And Margaret, maybe a comment. Well, hold the comment. We'll come back to it. Nicolas, we're back with you.
All right. Well, that's a good timing because we are wrapping up this case. So we managed to get the OCT catheter down and do another run. So maybe Quinten, you can show the run after the 3.0 by 48 Zion stent.
Yeah.
And then it was post-dilated more proximally with a 3.5 non-compliant balloon. And then this is the...
And then we do analysis, and yeah, the AI helps us with the analysis too. But then we see here the distal edge. It's okay, no dissection or something. The expansion over here.
So if you drag the distal, by the way, you see there's a D and a P there too, but they're reversed. So that's why I was commenting about it. But if you drag the distal edge of the stent a little bit more, it'll give you, there you go, you have an expansion index. But right now the expansion index is kind of at the stent edge. So if you just drag it more to the right, you should be able to get outside the stent, and then it'll give you what the expansion is relative to the normal segment. I don't know why that's not. No, yeah, there you go.
Yeah, there, and now it's on its 12.
Typically should give you
the
the
proximal.
I'm not sure why.
Yeah, the system was already over there, so I changed it a little bit. But okay, you see here, yeah, the distal edge, it's okay. The apposition is
appropriate,
yeah, at all places. But there was one.
And the reason it wasn't giving the expansion was because you have to click at the MSA to get it. But you can see here all this expansion is really great compared to the distal, but it's such a long lesion that it's less relevant here. Keep coming. And this looks great, guys.
Exactly.
Yeah. So and then we scroll to the proximal part, and that was a little bit discussion, I think, Nicolas, or.
Well, not so much discussion. I think. We were pretty pleased with the result. We had expected a little bit more resistance and a little bit more of a battle with this LAD, but yeah, it was really working in our favor, I think.
Yeah, good result.
So Nicolas, the question came up. Do you think? I mean, so for that distal lesion, what do you think that the OAS did relative to the NC balloon, or is there no way of knowing?
Well,
in other words, had you just gone in with the NC balloon there?
Well, you might want to think that you create some microfractures or something, some modification. With the orbit, theoretically, you do interact with the calcium in the media, and you might have these mini traumas within the vessel wall, but this is all assumptions, and it's very difficult to prove it. The fact of the matter is that we did our runs, very simple runs with the orbital all the way to the distal vessel, and then a 3.0 balloon, a 3.0 non-compliant balloon was expanding very easily. And then it always is the question of what would have happened if we would have not done the orbital. We don't know.
Yeah, but that's why we did Eclipse to see, and so we'll have some data that way. And I think also, having gone through that proximal segment where you heard the noise differences, it might have been harder to get the balloon down distal, et cetera. There were no hemodynamic issues at all in the patient with severe AS?
Zero. And that obviously is one of the advantages, as you mentioned earlier, of orbital atherectomy. As a matter of fact, so you never occlude the vessel. And if you have some debris that is embolizing, the fragments are so tiny that the likelihood that you will get no reflow phenomena are marginal, are minimal.
Got it. So maybe some takeaway points. This is a great demonstration. The final angio, I guess we can see on the left a little bit. Maybe just show us that so we can we can see it.
Can we show the last three angios? So this is an AP cranial, and then the previous one. This is an LAO cranial with a lot of superposition of small septal branches there distally, and then one more back. That is an LAO cranial. This is a good result, and this patient with severe aortic stenosis. Again, I think the hemodynamic stability is one of the arguments to choose orbital atherectomy in patients with severe aortic stenosis. You don't want to. You try to avoid hemodynamic compromise during PCIs. As a matter of fact, in the context of aortic stenosis, the scientific background to treat significant coronary artery disease is relatively marginal. It's not well substantiated, so much more research is needed and is also ongoing to determine how important PCI in the context of severe aortic stenosis is. But at the same time, as we are moving to younger patients, this is where I feel also the treatment of significant coronary artery disease remains mandatory. In a randomized study from the UK in octogenarians with a mean age of 83 years old, there was no benefit in treating concomitant coronary artery disease. As a matter of fact, it was associated with more bleeding. But obviously, that was a mean age of 83 years old. Everything will change if we have a mean age of below 75 years old. And again, this patient was 75. I think no point in not treating the LAD, in my opinion.
And Nicolas, what valve is the patient going to get in the study that you have? That's also probably relevant as well, right?
Yeah, that's a good question. It's going to be a Navitor valve. And that is because that is the only trial that is currently enrolling patients at low or intermediate operative risk. Formally, we are not allowed to treat patients with, for instance, a balloon expandable or an evolute valve because there is no reimbursement in the Netherlands for low-risk patients.
Got it. But that will have potential coronary issues, so also relevant for the treatment of the LAD. So we have everybody wants to comment, and we have some time. So Azeem first, you, then Margaret, then Giuseppe. Go ahead.
Yeah, no, I think you asked one of my questions, which was how the LAD stent would impact future TAVR choice and valve choice. Certainly in our practice, we'd probably do things a little different. We may have probably done the valve first. We can treat low risk here. So we choose probably a short stent frame and then come back and do the LAD pretty much the way you did it, Nicolas. But I think, I think the Navitor is still a good option. It's intraannular. So if you needed to do TAVR and TAVR in the future, the leaflets are lower than a supraannular valve, and it has quite large cells as well. So I think getting access in the future, should this patient have progression of disease or restenosis, I don't think you're going to have an issue.
I agree.
Margaret,
and by the way, there is a randomized controlled trial ongoing that is comparing exactly what you were mentioning, the timing of the PCI. Should you do it before the TAVI or after the TAVI? And this is the TAVI PCI trial. This is a randomized controlled study running from our friends in Zurich. So patients are 1-to-1 randomized to either PCI first and then TAVI, or TAVI first and then PCI.
I think if you add that,
only challenge with studies like that is for so many patients, it probably doesn't matter, and it's only a few that may drive it. But anyway,
yeah.
But go ahead, Margaret.
Adds to that, right? Sorry, go ahead.
And nice result, guys. Just one other educational point for the audience, or a point that's interesting to discuss. Your D2 was the more significant of your diagonal branches there. And all your branches held on beautifully. But I suppose it raises a discussion again about whether if you do calcium modification with atherectomy, whether we think side branch loss is less likely because you somehow reduce the volume of the calcific plaque rather than push the calcific plaque into the side branches. And there's been lots of discussion about this. Use a balloon, you can keep 2 wires, but if you do atherectomy, you reduce the plaque volume and you're less likely to shift. And I think in this patient, loss of that D2 would have been problematic with the AS. So, maybe another reason to debulk the disease.
That's a very good
Giuseppe,
comment.
what were your thoughts?
Comment, yeah.
Going back to the time, actually, what I think is important to understand what is the THV choice, because actually, if you decide to go with a short frame, I think I follow the suggestion of Azeem to perform the PCI after the TAVI. But if you have selected the tall frame valve, actually, I think it's better to do the PCI, complex PCI like this, before the implantation TAVI. So I don't know, Nicolas, in this case, what is going to be the THV that you select?
Yeah, so as I mentioned, it's going to be the Navitor valve because we are in the context of a prospective study. And I think the good thing with the Navitor valve, it's intraannular, as Azeem already mentioned. The cells are larger than with competitors. So if it would be needed to re-access the coronaries, I think we will be successful. At the same time, I agree with you. If you have to use a longer stented valve, then probably you want to treat the coronaries first and then do the TAVI. With short stented valves like balloon expandable, MyVal or Sapien, it doesn't really matter, I think.
Last point.
Yeah, these are all. Oh, go ahead.
Last point.
Go ahead, Giuseppe.
Yes, how much is the MLA of the proximal LAD by OCT?
4.4.
Yeah, there was actually a question from the audience about that too. That 4.4 though, was that at the area where the branch was though? It looked like it was calculating the area but wasn't incorporating, the carina in that. It's not clear. So if you maybe go back.
So why don't we bring back the OCT?
Yeah.
Can you see the OCT?
Not yet.
Yeah. There it is.
There we go.
Okay, so Quinten, let's just move more proximally. And so then we can monitor. So this is, there is a, is that 3.7?
Over here, yeah.
I was afraid about this.
Okay.
Yeah, but I mean, this is an area not touched, I guess. And,
exactly.
I think, and you could treat all the way. If you look at the longitudinal, you could basically treat almost all the way back another to where it says 10. And, then, it's...
I think it would be differently because you're there, you've done a lot of job, etc. So actually, I think it's better to complete the PCI there.
So you would stent it?
You could do physiology.
Yeah, I think that's the other.
I would go for stenting, Nicolas, because you have done rotablation, you have done so many things. So actually, for me,
no, but it's not.
I don't see the rationale to take it out everything, to put the valve and again to re-engage the coronary to perform another PCI there.
The only thing, Giuseppe, I mean, he did do atherectomy, but you can clearly see with the OCT that nothing is disrupted here, right? I mean, it's one thing if there was rota injury or stuff like that, but this all looks very clean and is just plaque.
And
so, but it's an interesting.
Yeah,
and
I don't.
The other problem is that your stent lands right at D1, and you'll get double overlap at D1.
So sorry, Margaret.
So you have to be sure that it needed to be treated with physiology, because if you put a second stent in, you'll double overlap at D1, and then you've got a chance you lock out the diag.
Okay, but how do we need to interpret coronary physiology in patients with aortic stenosis? That's another interesting question.
unpredictable.
but
I
if
would
You know,
leave it
it's, so
alone.
there's a, yeah, I would leave it alone too. By the way, there's a contrarian opinion in the chat that discusses this controversial issue of the fact that there's no mortality benefit in chronic coronary syndromes, and so how do we know that doing the PCI did anything other than increase bleeding risk for the TAVI? You know, it's a reasonable point, but I think this is why we need to study it, because the surgical standard for this patient, which is what you're doing your study to compare against, is going to be CABG AVR, and you know, I think that's why these are theoretical concerns, but we need to have data to prove it rather than leaving, you know, a pretty heavily calcified LAD behind. Nicholas, do you agree with that in a younger patient, especially? I mean, you kind of touched on
I agree with that. I agree with that. But, you know, in terms of our strategy, to come back to the strategy, what we definitely did is we treated the most challenging aspects and segments of the vessel. I agree with Giuseppe that, you know, if you will place a long-stented valve in front of the coronary ostium, yeah, that might add complexity once you need to get back in. But I feel that we could. I don't see it as unsurmountable. Obviously, if we would now want to treat that proximal segment, then definitely we would need to. We need to put a wire in the diagonal, and yeah, it might become a much more complicated PCI than we anticipated. And then I think we have to balance. Okay, but what is the evidence here? How convinced are we that we will affect clinical outcomes if we would continue stenting all the way to the ostium of the LAD. So that's why I think Wijnand, if you agree.
Yeah, I would not touch upon this proximal LED. Yeah. I would just leave it. The result is good.
I agree with that. A couple questions from the chat are, can you do FFR, can you do IFR? Yes, you can do all of those things. They've been done in this setting. Of note, though, for the lesion to be hemodynamically significant, you typically are going to need a more severe lesion than perhaps if you didn't have the AS. But you can definitely do it if you wanted to. But personally, I think I would leave it alone. So
can I say something? We have just completed the 5-TAVI trial. This randomization of FFR guided versus angio guided severe aortic stenosis. So actually, the result will be presented in the next. We need to complete the follow-up, so we need 6 months more. But there is a general concept that is true. That it's very difficult to understands whether or not to treat the patient. But actually, when you have a severe aortic stenosis and the FFR or IFR is 0.7 or 0.6, there is no doubt that the lesion is significant. Because the point is the opposite. If you have 0.8, after the relief of aortic stenosis, you might have 0.7. But actually, if you have 0.65 or 0.7, there is no doubt that after the relief of severe aortic stenosis, the lesion is significant.
Yeah, I think
that's going to be a really interesting trial, Giuseppe. We look forward to seeing that. I'm going to text you and tell you to present it at TCT, and right after we're done with the session.
Very good.
Any other comments? Thanks, guys. This is great.
The positive predictive value of FFR in the context of aortic stenosis is high. The negative predictive value is very low. And so we are also doing a study, it's called POTUS, where we do coronary physiology, all the indices that you might think of. We're doing them before the TAVI procedure, and we redo them after the TAVI procedure. And it's very interesting how these indices are changing just by treating the aortic stenosis. Yeah, so that story still has not come to an end.
And it makes physiologic sense because your EDP is going to be higher. It's similar to the heart failure type situation. But I think it's really going to be important to get the results of those trials for certain. Well, both, great job. Great to the team as well. I don't know, you know that there was a rota in one room, orbital in the other room. I think we'll make some summary points from the panel, but we'll leave you guys and see you in the afternoon for sure. So thanks.
Thank you very much. Thank you, everybody. Margaret, Giuseppe, Ajay, Azeem, ciao.
Ciao.
So definitely like to hear the panel's thoughts. I mean, two similar but different enough, subtle enough cases where I think the strategy's made a lot of sense. Very tight lesion treated with rota, longer segment, AS treated with orbital, different techniques, NC balloon imaging, putting it all together. Giuseppe, final thoughts on it? Tell us what you think. I think we've gotten a bunch of comments that the audience received it well, so that's great. But I thought it was a great demonstration on both ends. What do you think, Giuseppe?
Maybe I'll start with the case from Erasmus. I think that was really interesting because we almost forgot about it during the case, but this patient also had coexisting severe aortic stenosis, right? And you have to take that into consideration when doing complex case, procedures, coronary procedures in this patient. I like the discussion, and I think the discussion highlights how little data we have on how we treat coronary disease in the setting of AS. The one thing for sure is, for me, is we can't use data on chronic coronary syndromes without AS and apply it to this group of patients. We have to understand this group of patients, which comes to one of the comments from one of the audiences. I don't think you can apply that other data in the setting of valvular disease, but there's a lot of things we don't know. We don't know, how to evaluate these lesions before treating the AS. We don't know what's the best timing. Should we do it before? Should we do it after? So you've heard there's a randomized trial from Zurich looking at before versus after, but we don't even know whether treating it makes a difference. I have many patients with angina. Once I treat the AS, they don't have angina anymore, and I don't treat the coronary disease. So just to add to that, another piece of the information will be the complete TAVR trial, which is being run out of Canada, and that study, over 2,000 patients. They'll randomize patients after the TAVR procedure to either complete revascularization or no revascularization, which I think will also help us understand how important the component of coronary disease is versus the component of aortic stenosis. So I think there's three really important trials coming up. Some we will have soon, but some we'll need to wait a few years, that will help us understand those difficult questions that came up during our discussion.
Absolutely. And I also think that it's really important to also recognize that the conventional wisdom that there's no prognostic benefit to revascularization in stable syndromes like CCS, which is promulgated from the ischemia trial, is actually not true. If you look at the ischemia trial endpoint of myocardial infarction at 4 years, it is less in the cath arm than it is in the medically treated arm. And that's not something that people actually know, but we should all know this as interventionalists. It doesn't mean we revascularize everybody, because we do cause more paraprocedural events, but it is an important endpoint nonetheless for patients, especially in a lower risk group. Margaret, what are your thoughts? And then we'll get to Giuseppe.
I think the Erasmus case illustrated the discussion earlier about how patient factors are really important in how you decide to conduct your procedure. So they made a decision on their strategy based on the fact the patient had severe aortic stenosis, and I think that illustrates that point well. The other case I thought was quite interesting because angiographically that looked like it was a nodule sitting right in front of the diagonal, and obviously we didn't get imaging until after they had performed the rotational atherectomy, because it was a really classic rota case where, the wire would cross and microcatheter struggled. Actually, once the IVUS afterwards, there was very little nodularity there at all. It was mainly concentric and eccentric calcium. So whether they'd completely obliterated the nodule or whether actually the angiogram was slightly fooling us, and actually what we were dealing with was an eccentric shoulder of calcium in that bend, I think that was quite interesting.
For sure. And Giuseppe, final word. You have 1 minute because of the I talked too much. Sorry.
What I think is that, my perception is that we don't need to do too many PCI simultaneously with TAVR. So the point is that by ES guidelines, the recommendation is ACS, of course, and 90% lesion of the proximal LAD. But actually, this recommendation is level of evidence C, and this may be granted it's a matter of opportunity, because sometimes you go with the tall frame valve, and actually you might have some problem in terms of orientation and then to re-engage the coronary artery. So this is not science, this is just opportunity. And we need to, look forward to the upcoming trial that Azeem said they're coming up.
Oh, great summary. And again, great cases on both ends, imaging, calcium. The didactics were really, really relevant too. So I thank all the speakers for that. And we're going to wrap this session up. Key takeaway messages: calcium is bad. Know all the techniques and stay tuned for randomized data, but also be very flexible in your thoughts and flexible in your approach to patients, because that's the way to benefit them the most. Thank you, Azeem, Margaret, Giuseppe, also Holger, Nicolas, and the team. Stay tuned for the breakout session. It's called IVA Saves Lives, From Data to Practice, and the main program is going to resume just after this session in about an hour. So thanks, everybody.
Thank you. Bye-bye.